Thank you so much. It's very nice to be here, and thank you, Sinuja, for inviting me to this project and meeting. It will be very nice to meet with you all. I'm a neurologist and neuro-ophthalmologist and working in neurology clinic Altunizade Hospital, Acıbadem Hospital, and also Istanbul University. I'm going to talk about the challenges of MS diagnosis and treatment. We'll talk about Turkish healthcare system, diagnostic challenges, local standards of care, reimbursement policies, treatment costs, and also challenges in patient management. So healthcare in Turkey is just transformed a lot in the last 20 years. The health transformation program implemented in 2003, and there were like 5 major insurance schemes before that, but they combined it all to a single payer. And everybody got registered with the general health insurance in 2006. So all citizens are registered to a social security institution. And this is free healthcare and comprehensive coverage. So you may have some cost sharing, but it's like visit to primary care providers, no payment, and for the chronic illnesses, treatments has no payment as well. You just pay like a co-insurance if you go to a provider, but this is like a symbolic, it's less than €0.50 per visit. So it's basically a free healthcare, and virtually almost all citizens are registered to the general health insurance. But like 10% of the people has some private insurance. This is under like limited agreement with social security institutions, sometimes as a complementary coverage. And this is just for go to the private hospitals. So when you look at the healthcare in Turkey, you see that we have very lowest among the lowest rates of physicians and nurses in the European Union countries and the European Union region. So, and also less hospital beds compared to EU countries, but it seems like similar to Netherlands, I think. And so there is like a shortage of physicians and nurses. Basically, the system divides into like 3 levels: primary care providers like family health centers, community health centers; secondary healthcare providers, state hospitals; and tertiary healthcare providers are research and training hospitals and university hospitals. Normally you would expect the patient to go to their primary care provider, and in need the primary care provider can refer them to a secondary or tertiary healthcare providers. But with the health transformation program, they all just canceled it. So anybody can go anywhere, anytime, as much as they can. They can get an appointment from a neurologist like 10 times in a day, different neurologists in the same day. So this is like a wasteful of resources, but it was in the beginning the public loved it because, you know, they can go anywhere, anytime, as much as they want. But with the lowest rates of physicians and nurses, this caused some really high workload. So total of around like 1,600 hospitals in Turkey, like most of them are Ministry of Health hospitals. There are some private hospitals, but so less of them are tertiary healthcare providers. So when you look at the outpatient visits in 2023, in an 80 million country, we had like more than 800 million outpatient visits, and it's more than 150 million emergency care visits. It's something that you can't imagine. It's too much workload, and this caused like the examination times, appointment times, just less and less. And normally now in Ministry of Health hospitals, in the state hospitals, mostly it's less than 10 minutes in the most hospitals. So when you look at the MS in Turkey, so before this study from the last year, we thought that the MS prevalence is like between 40 to 60 per 100,000, but we learned that it's quite higher than we were thinking. It's 1 in 1,000, still half of the Netherlands. But you also see that the prevalence is, the disease is more prevalent in the western and northern part of the Turkey. So there's like an underserved areas, probably in the southeastern part of the Turkey, like unequal distribution of the healthcare providers may cause some less prevalent disease over here. So the incidence rates are still lower than the northern European countries, but it's quite much, 6 per 100,000 per year. So to diagnose MS, you need like 3 components. One of them is like clinical evaluation. So we have less and less time to evaluate the patient. The another one is MRIs. So when you look at the MRI devices number in Turkey, it's again low compared to the European countries, but still a little bit close to Netherlands, not bad. But the issue is that, like we have like 1,000 MRI in the last year, but the issue is that number of MRI exams per 1,000 population, it's the highest among the European Union. Because we have like less and less time to evaluate the patient. So you just order an MRI. Also, it's due to some like defensive medical practice, due to the malpractice cases. So you don't have time to examine patient. You don't have like cover everything on that exam. So you just order an MRI and you can say that in the later, I ordered an MRI, there was nothing there. So I think the most of the part of this MRI orders are due to that. But like we had less MRI devices with high MRI exam. So this is due to like highest number of MRI per scanner. I think like virtually all MRI devices works 24/7 in the whole country. So that's how we reached that number.
And also for patients at night?
Yeah, at night, like 24/7.
So 3 o'clock at night would be your appointment for your lumbar spine.
Absolutely. And in the beginning, again, the public loved it because they can do MRIs in like within a few days. So yeah, that was another issue. But this caused also some like increased demand, and then this caused like insufficient imaging, like low quality MRIs, like all the technicians are trying to do it quickly because there was also a pressure from the top, like Ministry of Health, just make the appointment waiting times lower and lower, shorter and shorter. So they try to do everything faster, and this caused some insufficient imaging. Sometimes I've seen some patients without even FLAIR MRIs suspected with MS. So it's really hard to standardize the MRI especially in the Ministry of Health hospitals. But the university hospitals are still protected. They are not, owned by the Ministry of Health, most of them. They are, their own hospitals, and they can decide the appointment times, and they can, implement their own protocols as well. So there is also some like subspecialty outpatient clinics that you register the patient to it, and only like an MS clinic, only those patients can get appointment from that clinic. So you can have some more time to deal with those patients. The other aspect is the laboratory studies, that you need to do some CSF studies also to exclude some other autoimmune or inflammatory disorders, some laboratory studies. For the CSF studies, yeah, you can do it most of the hospitals. But you need some oligoclonal bands which needs some expertise to read that. It's actually a basic technique, like just as gel electrophoresis, but you need an expertise to read that. But there are a few big centers that you can send your specimen like all around Turkey to them to, get the oligoclonal band results. With the new criteria, we would expect to have kappa-free light chain studies as well, but there is still no institution that does CSF kappa-free light chain as far as I know. So the diagnosis and treatment, not only the MS, the whole diseases are regulated by healthcare authorities. Everything was just so centralized after like 2019 in Turkey. So there is a circular that's called a health implementation communique. They just update it like every few months or while they get anything new. So it just states the scope of all the treatment and reimbursement policies and all the processes that you can get. So we treat the patient according to these health implementation communique, because also there's like a single payer, there's just one institution, the all public just registers, so we need to follow these guides. So the secondary health providers can do the diagnostic tests like MRIs and lumbar puncture, but they can't decide the treatment, like start the treatment. They need to be, the MS patient needs to be, started the treatment within the tertiary healthcare providers. So according to that health implementation communique, they just divided the medications to 3 lines. The first line treatment, as you know from the AVAS talks, like teriflunomide, glatiramer acetate injectables, and dimethyl fumarate. These are the first line treatments. And you need to start with those and use them at least a year. And the second line treatments, S1P modulators, fingolimod, we don't have ozanimod, siponimod. Actually, we have ozanimod, but it's not reimbursed yet, I think. You can pay and get it. And natalizumab, ocrelizumab, and cladribine. Cladribine has a special, regulation about it. It's just in between the first and second line in Turkey. It's something new that this summer they implemented. And the third line treatment is alemtuzumab. So you need to start with the first line treatments when you diagnose a patient. So you need to diagnose with 2017 McDonald MS and by a neurologist specialist and a tertiary healthcare provider and facilities, and we need to issue a report for medication use for reimbursement. So no reimbursement for clinical isolated syndrome or radiological isolated syndrome. And so after you start the first line treatments, how can you switch them? So there are like basic 3 components. So it defines a relapse, like at least a relapse within the last year, or MRI activity, or enlarged T2 lesion, or gadolinium enhancing lesions, or a disability which was defined as 0.5 EDSS, confirmed EDSS increase in 6 months at least. But after first year, if you have like at least 2 of these 3, you can switch to a more potent treatments. So about the cladribine, the issue is that if you get the 2 of the 3 activities of this, like relapse, MRI, or disability activity, you can start cladribine without waiting 1 year, or it's just available as a first line treatment in a group of patients. A patient just got diagnosed with MS, didn't want to use the medication, wanted to be followed up, like 3 months later, get another relapse, you can start with the cladribine. But starting another DMT within 4 years requires the permission from the Turkish Medicines and Medical Devices Agency. Again, the issue with alemtuzumab is that you need to use second line treatments at least a year and see the disease activity, and you have like 5-year limit for this treatment. So if you want to start, within the scheme, you can start high efficacy treatment within a year. That's quite nice, but also if you want to start an earlier higher efficacy treatment, then you just apply for an off-label use, and then if they approve like 6 months or a year, you can use that. But again, after that period of time, you need to reapply. But the issue is that you don't get a consistent responses. You think a patient needs a natalizumab like the other patient that you have, and you start natalizumab, and a year later you just apply for it again to continue the treatment, and they just reject it. So if they reject it, you just stop the treatment right away, and you have to deal with the rebound activity as well. So you need to go back to first line treatment, or the cladribine might be another choice. So we normally do not, go through that pathway because of these things. So normally we try to do, start with the higher end of the first line treatment like dimethyl fumarate, and then increase like the escalate the treatment just right after the 1 year. So the treatment costs in Turkey per year per medications, it's like quite high for ocrelizumab and natalizumab, but the other medication looks like all similar. The red ones like ozanimod and ofatumumab is not yet reimbursed. As you can see, the rituximab is the cheapest one. So the price is also different than the Netherlands. You may just notice that, because there is a single payer, they decide. They own currency. There is now today is 37 Turkish liras equals to 1 euro, but the Medicine and Medical Devices Agency decides that it's now 23 liras. So I buy these medications with this currency. if you want to be in the Turkish market, yeah, you can sell it to me from this price. If you don't want, yeah, I'm not gonna buy it, and you're not gonna be in the Turkish market. So this caused some like lower the costs to the government, but yeah, and also it makes maybe easily accessible to rituximab as well.
I think it's interesting that you can double it, and then you have the Dutch price.
Yeah.
Whole line. So if you double it, ocrelizumab is 25,000 euros, rituximab 4. So yeah.
So the rituximab is also within the off-label use in Turkey as well. The private and public care, there are some differences in that. So you can get like a faster appointment in the private care, but longer waiting durations in the public hospitals. But getting an appointment is not like waiting for a line. So the new appointments are, they open new slots for every 2 weeks. So you have to wait in the, computer or in the phone line to get another appointment in 2 weeks. So if you get an appointment, you're gonna be seen in the 2 weeks. But if you can't, you can just, infinitely wait. And access to treatment is limited by SSI criteria, which is not too bad. You can start the higher efficacy treatment within a year. And the issue is about the multidisciplinary care. This is like limited and less prioritized in the public care hospitals. The cost is also low in public hospitals. But the issue about the challenges in patient management, absolutely the unequal distribution of neurologists and MS care centers, as you see in the prevalence of the disease, and the workforce limitations. And as we talked a lot today and yesterday, so we mostly focused on the pharmacological treatment, but MS patient needs like a multidisciplinary care. The physiotherapy should be included, occupational therapy, social supports, urinary and sexual health management. So it's like a lot of aspects that's important for the quality of life. So there is a lack of multidisciplinary care in most centers. So there are also some coordination issues. And another issue is that the inadequate patient education and public awareness. There is still like a stigmatism and misunderstanding that when a patient diagnosed with MS, they're just completely usefulness, and they can't do work, or they can't have a children, or they can't have a family. There is also still some misunderstanding. So we need to do more public education and public awareness, and we need in Turkey, so we need an equal distribution of MS care centers with multidisciplinary care. Thank you so much. It was a quick and brief talk, and thank you.
I guess there might be some questions for Serkan. If there are any, please go ahead.
I have one. How is patient information distributed? Do you have websites or folders, or I'm asking because we are struggling with that in the Netherlands. We have recently gotten a website that it was built for all the patient information and also the patient communities together with the scientific communities.
Mm-hmm. So there is a system called e-nabız in Turkey, like e-pulse. So all the medical information from all the hospitals, like even public and private hospitals, they are just upload all the information to there. There's like a one single system that physicians can access. And patient can limit access preferences. They can limit by SMS confirmation or like two-factor authentication. But basically most of the time the provider can reach all the information. We have some patients like outside Istanbul that we are treating, like 4-hour driving away. We just tell them we started dimethyl fumarate, do a blood work there, and just tell us that you did that, and we just can access to that information and communicate with the patient. It's very nice to have all those information. Also, patients, usually do not, have all their information from the providers, like no MRI scans, no blood work. So they just come and somebody told me that I have MS. So it's so easier to, get into that system, see the MRIs, and sometimes, when patient just comes in with the first episode and first MRI, they just tell that like, this is my first episode, you are just in between, is it like a clinical isolated syndrome, so can I start treatment? You just go into the e-nibbles and you just go back like 6 years ago, they had a brain MRI for headache or some other stuff, and you see that there is no lesion. So you can just diagnose them with dissemination in time. So this is also useful for that. But the issue is the privacy. So we had, I think, there might be a leakage that's been told in like 2-3 years ago within the pandemic years. Government doesn't accept it, that there is a leakage, but we knew that some information of some people are just going in the dark web. So that's the drawback of this thing, but it's really nice to have all the information.
Yeah. Are you asking about the patient information or patient like awareness and then, you know, informing
I think
patients?
it's actually both. Yeah.
So are there any like MS society?
Yeah, there are lots of there are lots of like patient societies, MS society as well. They are, you know, organizing meetings and like in, you know, in person and also online meetings, and their patients can go there and get some advices and physiotherapy and stuff, but it's not so well distributed the whole country. Yeah. You can find those societies in the big cities like Istanbul, Ankara, Izmir, but not in the, you know, eastern part of the Turkey a lot. That's another.
It's organized per city, but not.
Yeah, not in the whole country.
Yeah. Actually, one hopefully goal of TACTIX is to create such information. And you know, communicate with patients, inform them of their disease and treatment options maybe, or you know, anything that might be of interest to them. And it is nice that we have Duygu today with us, who's going to be representing the local MS patient population, and maybe Duygu might have something to say about those. And then in the yesterday's dinner, we were talking with her about how we should establish such, you know, outlets. And we don't have to make it all Turkish. We could also create some English content, I think, and we could all contribute. That would be very nice.
Right.
And I share with all our patients, I guess, in both countries, and hopefully more. Thanks. So thanks again, Serkan.